Thank you very much. It's indeed a pleasure and honor to be here today in the warm confines of Florida versus the capricious Northeast. I started the week with snow and I ended with 60 degrees yesterday. So stay tuned for what we may receive tomorrow when going back. In any case, it's an honor and pleasure to be a part of this distinguished panel of speakers, and I hope that in my 40 minutes with you that I impart some of my enthusiasm, experience, and growing knowledge on what I think is a real game changer in implant dentistry today. My topic is, can a protocol using densification modify the way we approach loading? Now, for those of you in the audience who are clinicians, you might hearken back to the days when you had young children, or if you still have young children, you go on a trip. Well, when you go on an implant trip with your patients, it's not a heck of a lot different than when you go on a trip with your kids. As soon as you get in the car, as soon as you start surgical treatment, the patients want to know, are we there yet? Throughout the entire process, they want to know, when am I getting my crown? And it drives you nuts as a clinician. It absolutely drives you crazy because they're always in search of the end point. So, when you start and you have the problem such as this, and even if you provisionalize, patients aren't happy until they reach this, the final crown. So, anything that can bring the outcomes to patient-centeredness versus clinicians only is welcome in my armamentarium. So I want to introduce you to the 3S principle of osseointegration as I see it today. 1, you always have to proceed safely because it's primum non nocere, do no harm to your patients. 2, you want to proceed as fast as you can. Speed is key. Patients want to get done. You want to see more patients. You want to treat more people. And last but not least, what I think that Versah is doing so beautifully is you want to proceed with scientific evidence. So scientific basis is key. Which brings us to today, my topic, the Versah way. So the 3S principle starts with your problem. You want to proceed safely. You want to move to a provisionalization as soon as you can. This happens to be an immediate provisionalization. And you can see that we try to keep things provisionalized and not necessarily loaded. This patient happens to have a bit of parafunction, so I try to keep this out of occlusion, and you want to get to the end point, a final crown. And in many instances, what I'm beginning to see more and more, that the limiting factor in this is not the hard tissue, but it's the soft tissue maturation. So the question I ask of you in the audience is, what tools are you using to assess your journey today? Are you using touch, traditional, 2 mirror handles, reverse torque, or are you quantitatively and qualitatively measuring ISQ or RFA value? Removal torque test, in my opinion, and that of Mirels, Wennerberg, and Albrechtsen, is a 3-dimensional test reflecting interfacial shear strength between bone and implant. But I ask you, when you put these poor little animals and your patients in this test, what does this have to do with occlusal forces? This has nothing to do with occlusal forces on an implant. And if you come away today, you have to start changing your paradigm to that which has been employed for the better part of about 4 to 5 decades now in the discipline known as implant dentistry. What I find interesting is if I put the question to you all in the audience, which car would you prefer, the one on the left or the one on the right? I'll bet 99 and 44/100ths of the hands show the right car. But if I ask you, which do you prefer to check your implants? Most of you are raising your hand for the mirror handles and the reverse torque. That's barbaric to me. I don't understand that. We have much better methods of qualitative and quantitative analysis. And insert torque, which I will show you a little bit in my evidence today, does not have a lot of correlation with RFA, which measures resonance frequency analysis or tipping on the implant. What are the benefits of using resonance frequency analysis? Well, first and foremost, it's an objective, non-invasive method of gaining quantitative data on the implant-to-bone contact. It aids in the detection of whether to place the implant as a one- or a two-stage procedure. At least this is how I use it. And last but not least, it objectively helps in the decision of when one is going to provisionalize and or load versus when are you going to wait. A brief on some of the evidence behind this is that if you look at Carl's from COIR, measurements are sensitive to the anatomic site and are only valid when you measure in a repeated basis over time. And this is a prevailing theme. It's not necessarily a one-time measure, as I will show you today. It can give you a lot of good information, but its strength is really in seeing it over time, as Salah showed in his very first lecture, where he showed 1 week, 2 week, 3 week, all the way up through 8 weeks. RFA does not correlate well between implant systems because they have all different footprints. It's influenced by the transducer that may be used as well. So because you use one type of implant versus another, the RFAs cannot be compared. Remember, this is a serial system where you're looking at an implant or an implant system over time, not one system versus the other. This study by Bellari and colleagues is one that I want you to keep in your mind today, because what they showed is that when you look at RFA or ISQ values, implant stability quotient, which goes from 0 to 100, they found that implants that had 57 to 82 would be successful in their study. Notice 82, and 82 is because that was the top levels they were primarily seeing. In their study, they found if you were 70 or better, that was very high stability. And I want you to remember that when you look at the values that I am achieving when using a densification protocol for drilling. And last but not least, as I said, the strength of this test is over time. Looking at 2 time points, the RFA values, which should also be looked at not in one direction, but in more than one direction, because the RFA in the buccal lingual or buccal palatal direction may be well different from that in the mesiodistal direction. So how does Versah use relate to this thought process? Well, I think, and I really applaud Salah and Eric and all of Versah, because they're considering the biology, and the biology starts with wound site preparation. We know that in periodontics because we try to prepare teeth for healthy periodontal outcomes. It's all about wound preparation. And in implant dentistry, we've never really looked at it in quite that manner. We've just always looked at it as drilling a hole for a highly osteoconductive implant or screw to be placed and hopefully have that induce or be conductive for healing. Well, it really starts with the manicuring and the treatment of the site. And I applaud Versah greatly because we're changing, or they're changing the paradigm and helping our patients and helping us in the process. So the osseodensification protocol is a basic belief that surface modification and implant macrogeometry are not the only means by which the speed of osseointegration can be improved, and that most drilling modifications to date have been on subtractive methods that remove bone chips created to enhance osseointegration, while osseodensification looks at this by seeing the merits of maintaining the autogenous bone at the site. And this is a huge paradigm shift, because I still think back when I look at the all-on-4 concept video of Paulo Malo flushing out the site to make sure it's pristinely clean, almost as if this bone debris, and it's a very poor term, I would rather look at it as a self-contained coagulum, but that this is a debris that impacts osseointegration in a negative fashion rather than a positive one. So what we're trying to do here is, number one, we want to minimize osteocyte death in drilling if we're looking at the biology. And Eric did a beautiful job of discussing this in his presentation, as did Salah. You're looking at somewhere on the top end of about 1,200 for the speed. We want to look at preserving the bone chips in the body because, as we are seeing through Coelho's research and others, that these bone chips are very, very conductive for new bone formation. And these are just 4 of the emerging studies on this. The first by Cold that was highlighted by Eric back in 2005, looking at bone compaction. Rossi's, where bone healing patterns and surgically created circumferential defects around submerged sites also showed where these bone chips act as foci for new bone formation because they're very chemoattractive. Layens and colleagues also showing the same phenomenon. And again, Cold and colleagues looking at compacted cancellous bone having, as Salah pointed out, this spring back or elasticity phenomenon to it. So, last but not least, we recognize that bone is a living tissue, and we want to try to minimize the amount of torque that we place on our implants. Enough to stabilize, but we don't have to crank them to the point where we're causing microfractures and things we just don't see in the bone that are deleterious to our efforts. All of this translates to, hopefully, avoiding that dreaded dip. The dip is where we see a diminution in stability, where we start out with mechanical stability and we cross over to the area where we now have osseointegration or biologically contained stability to the implant. I talked about this in a paper and described a phenomenon never talked about before called the bump, where in this zone of where we saw dips, we were actually seeing increases occur in RFA values. And this was first described back in 2010 by myself with Mark Reynolds and Neil Meredith. What we used to delineate whether a bump occurred was plus or minus 3 RFA units. And this was based first on the work of Netter and colleagues, which showed with the conventional ISQ or the RFA values, a plus or minus 3, there was very little but still some error. And with the Mentor that's now used, we can see that when you get beyond 2, you're going to be within 2 ISQ units, you have pretty much consistently shown that you have a stable situation. So we know the error of the machine to be plus or minus 2 units, ISQ units, going from 0 to 100. Anything beyond that we would assume to be a bump if it's greater or a dip if it's less. So here was a patient from that time where we had a recurring abscess retained primary tooth that was extracted. It was determined that I would be able to place an implant, albeit a 7 millimeter long, which is a little bit more of a challenge. We know that from Frank Renoir's work that short implants can do the trick. I'll be curious to see someday if osseodensification will be used to drill through teeth, as some articles have shown, and serve to provide stability in a healthy impacted canine. My comfort level is not quite there. So I placed a short implant that you could see had an insertion torque of 32 Newton centimeters and an RFA or ISQ value of 60 in the buccal palatal direction, 76. Now 60 is a little bit lower than what we'd ideally see, but 60 is not a bad number whatsoever, and 76 mesiodistally is very, very high. At 2 weeks, though, when I checked this patient, this was a male in his mid to latter 50s, constantly traveling, wanted to get done like yesterday, didn't have all the time in the world. Caught him during a period where he was doing less travel. So we checked the RFA values, 73, 76. So I decided if this was indeed the case at 4 weeks, which you can see there was some coming back. We had basically stability versus the beginning. 74 to the 76, and 72 still bumped in the buccal palatal direction. So we were able to complete the restoration. And this is objective data. The nice thing about it being objective is that when the patient says to you or to me, Dr. Rosen, can I get restored? And the readings went down, I say, well, you're telling me you don't heal fast enough. It's not me as the bad guy. It's the objective data. Or the data tells me you're ready to go. So the advantage of having this dispassionate measurement system is wonderful for patient explanation and for prognosticating whether I can move forward. So let's have a look at what I've seen with osseo-densifying preparation of the sites to a system that has an electrowetted implant surface. Now, the only chagrin that I have behind this information is that it's been done during my learning phase of treatment. So if I had to do it today, I might even do a bit better. But the take-home message is that there is indeed a learning phase to using this system. It's not a conventional drilling system, and it's not just drilling all in forward or drilling all in reverse. Sometimes it's going forward and then at the end coming out. Sometimes it's going forward, then backwards, forwards and backwards, constantly moving forward in your direction, but with this back and forth direction to the burr. And sometimes it's all because of the bone density, strictly a reverse drilling protocol. So unfortunately, throughout going through this, I was a bit in the learning phase. So, you know, the data is the data. When I had this analyzed, and I have to thank my dear colleague Mark Reynolds, who's collaborated on a number of papers with me, we had the assumption that this is non-parametric data, which assumes that there's not a specific distribution to the data itself when analyzing it, for those of you in the audience who are statisticians. For the rest of us, it leaves us shaking our heads saying, okay. So the preliminary look at this information was 31 patients in my private practice, consecutively treated, 18 male, 13 females, came in. Total of 41 implants were evaluated, 22 in the males, 19 in the females. For all intents and purposes, this is a non-smoking population. There was one smoker who was less than 10 cigarettes per day. This is the realities of what I see in my US-based practice today, fewer and fewer smokers in general. So by and large, the people who come into me are non-smokers. The maxillary arch had 17 implants placed, whereas the mandibular arch had 24 implants placed. And if you look at the ratio of immediate to delayed implants placed, 20 were immediate, 21 were delayed, not provisionalized. Immediate upon the time of extraction of the tooth, delayed, they had been extracted in the past, either by myself or others, and came in for the implant. When you look at it by areas, I had about an equal distribution in the maxillary arch between premolars and molars, in the maxillary arch between premolars and molars. The mandibular arch was much more heavily weighted towards mandibular molars. So when you look at the overall averages for insertion torques and implant stability, RFA values, let's take a look at this. So in terms of insertion torque ranged anywhere from 26 to 60, which is pretty darn good, because I think everyone would agree, you have 25 or better, that's a pretty good value. Now, some of you wouldn't feel comfortable with that because insert torque is everything in your world. And so with that insert torque, you'd be fretting, taking out the implant, trying to get more, embracing a system that gives you 40, 50, 70, whatever it may be. But 26 to 60 is quite fine because you're going to have a stable implant. When we look at the ISQ values, remember, 65 or better is a darn good number. On the minimum, 63 in the buccopalatal and 67 in the mesial-distal direction, up to 86 and 85. And quite a number of these were in the upper 70s to 80s. When we look at this at 2 weeks and 4 weeks, please note again that the numbers slightly move up. For all intents and purposes, you could make the case that we've achieved a stable outcome with regard to implant stability over 2 weeks and at 4 weeks. And that's very heartening, because what it's telling me is that perhaps I should be going to an earlier provisionalization protocol or an immediate provisionalization protocol when I'm placing my implants, which is what patients desire. They would much rather have crowns in their mouth as soon as possible, particularly anywhere that is in the quote-unquote aesthetic zone. What is the aesthetic zone? Well, if you're Julia Roberts, that could be a maxillary first molar, in fact. I mean, she has one of these unforgiving smiles. The last person in the world you want to see come into your office is one of these high gummy smiles, and you're saying, oh my God, thin biotype, high gummy smile, and I'm going to have to make this work. Nevertheless, they also are the people who, when they don't have a low lip line and barely show teeth, want their tooth in there as soon as possible as well. So the sooner we can get to that endpoint for patients, the better off everyone is going to feel and be. So here's some of the case examples that I'd like to show or share with you today. This happens to be a male in his early 60s who comes into my office and lower first molar is missing. So I place an implant that has an insertion torque of 50 Newton centimeters in an RFA value of 8682. Now, I've used this system for quite a while, and I can tell you, historically, I was never getting numbers like that, which concerned me. If I had an insert torque of maybe 100 or so, I might even be even more worried that I might be over-torquing, over-stressing this. But the RFA values that I've seen when using a densifying protocol have certainly increased. Now, this happened to be a type 2, type 3 bone case. I placed a healing abutment on and brought them back at 2 weeks. And if you notice, at 80s, you would expect, and many people would tell you that with RFA, there would be this regression towards the mean or this coming down effect that you would see. But it stays at 86, 82. Which blew my mind. I did not think it would remain that high. I thought, yeah, maybe it would come down to 80, 80 or stay in that area. But believe it or not, at 2 weeks, it stayed stable. And when I looked at 4 weeks, the mesiodistal measurement even went up, which I couldn't believe. I never thought the 86 for sure would never go up. But the 82, I strongly doubted. Again, thinking that at 4 weeks, perhaps this would diminish. Here's another scenario. Again, an edentulous patient. This is a woman who's in her mid-60s, came to me for an implant. I had not extracted the tooth. The tooth had already been out. In the former case, I had removed the tooth months prior. So in this scenario, again, I placed the implant. Now, for some of you, you would be much more inclined to do these as flapless cases. I happen to like to see the anatomy. I sometimes am a little bit concerned with how thin the labial area may be and whether any augmentation may be needed, etc. We can agree to disagree or do this in different fashions, but this is the way I tend to do edentulous areas. So I placed the implant in. This, I think, was about a 4x11. Bone type was, again, type 2. Insertion torque, 50 Newton centimeters. The ISQ in the buccal direction was 68. Mesiodistally, it was 80. Again, transgingival placement. We allowed this to heal. Brought her back at 2 weeks. And at 2 weeks, it still remained stable. 68 buccal lingualing, mesiodistally 80. This is a scenario, 65 or better, I would feel very comfortable having provisionalized, quite candidly. Had it been in the aesthetic zone today, I would strongly consider that. But at 4 weeks, notice the 68 jumps to 80. Now, under the traditional paradigm, we would just hope that things would stay stable or slightly dipped. But here, we're seeing this move up to 80. And I would tell you, my colleagues, that I believe that maintaining the autogenous bone in the sites is acting as foci for new bone formation, as Paulo Coelho is showing, and Langens and all the others have been demonstrating. I believe that when we're seeing these earlier moving up, or even some of the stability, it's look at this as a mechanical coagulum. Look at this as a biologic nidus for new bone formation. You have to change your thinking. We're not trying to just densify bone when we're doing this. We're trying to create a biologically active site to enhance regeneration around, or osseointegration around the implant. So let's look at the data that Mark Reynolds was kind enough to analyze for me. And let's look at the Versah use with a proactive surface, bumps versus dips, which means a plus or minus 3 ISQ units at 2 and 4 weeks when we look at the buccolingual or buccal palatal direction. And what we basically see at 2 weeks is that the vast majority of the sites are either green, being stable, no change, purple being slightly increased, or a bump, meaning 3 RFA units or greater, with very few being diminished or dipping. Okay? And I'm going to go over the raw numbers a little bit later on that. When we look at 4 weeks, again, we see a slight increase to some of that dipping, but I tell you that the dips, as you remember from the original raw numbers, were never really below 68. So yes, it's diminished, so we see some biologic changing of the site, going from mechanical to biologic osseointegration, but the vast majority of our implants are stable or moving forward biologically at a rate that we haven't typically expected. So after 4 weeks, this patient is able to get restored. And the problem that we have with our patients is not the hard tissue healing so much so, especially in the anterior. It's that the soft tissue healing lags behind the hard tissue healing, I think. Here's another scenario. Now, I know that I like to save teeth an awful lot. I do a lot of furcational therapy. But with the caries that is present in the furcation, and this being a class 3 and a poor fitting crown, even I can't save this one. I think that this is best saved in a glass jar. So tooth was deemed to be poor to hopeless. It was extracted, and an immediate implant was placed. Insertion torque, much like the others, is about 50. We're not over-torquing these implants. And the ISQ values were 75, 75. The site was also grafted with a combination of demineralized and mineralized bones, 70, mineralized, demineralized, 70 mineralized, 30 demineralized, and a barrier material was placed just to contain the graft. So this is the way it looked when the patient left. He came back 2 weeks later. Look at the ISQ value. Went to 85. Never would have expected it to jump like that. Never would have expected it. So what's the problem here? Well, provisionalization, yes. Final loading, no. The soft tissue still isn't there. We look now at 4 weeks. The 85, 85 isn't biologically dipping down. It's remaining stable. It's remaining stable, my colleagues. So this is a scenario he should go forward. My patients are often dumbfounded when I said it's 4 weeks, you can go get your crown. They say, are you kidding me? I said, no, you really can. You're healed. You're not going to diminish. So when we look at the ISQs in the mesiodistal direction, what's really telltale, unlike the buccal palatal, and I think the difference between the two is that in some of the immediates, you have that gap that occurs. So any of the primary mechanical stability is from the palatal or the lingual and mesiodistal where you have that buccal gap, whereas with our immediates, when we measure mesiodistally, we have pretty good mechanical stability. So any loss or changes might be compensated by the new bone formation. So in the mesiodistal direction, we see more sites at 4 weeks that are stable to their initial measurement or bumped, but very little that have diminished values or dips. This is very exciting because if we look at this in terms of stability of our implants, in at least two of the directions, we're getting great stability. The other is good, albeit at times a little bit diminished, but overall, we're having a nice, stable scenario to proceed with patient care. And this was restored before 3 months. It was restored at 8 weeks. So what have been my observations for the data when I've used the Versah drills? First, the predictive value is much greater, as I showed you, in the mesial-distal direction readings than in the buccolingual or buccal palatal. Second, when you look at arch correlation with ISQ values, you are more likely to see a bump. A bump is more positively correlated in the mandible. As Salah was saying earlier, the maxilla is a little bit more capricious when we look at bone, whereas a dip will be more likely correlated with the maxilla. So the take home in English is that if you're going to see bumps, you're going to more often than not see them in the mandible. You can proceed a little bit quicker in the maxillary arch. You're going to more likely see a dip. It'll be more correlated to that arch. Immediate implants more likely to see a dip at 4 weeks. Again, I think that's because of the gap, particularly in the buccal palatal direction, and particularly so because there is not, that dip is going to occur because we don't have as much stability on initial insertion mechanically. The RFAs tended to remain high, better than 70 ISQ, even when there was a slight dip. So yes, we see dips, but in overall numbers, they're very, very stable. The internal validity of this, how do we know that this is all true? Well, the patients who had a bump were not the same as those who were seeing dips. So we know that these measures are valid. The second thing is when you look at the R value for torque, and this is what everyone is talking about here, when we look at the correlation between insert torque and RFA or stability, there is a negative R of minus 0.41 with the bump seen at 4 weeks. So in other words, insert torque does not positively correlate with seeing a bump. So if you have a high insert torque, you're not necessarily going to see a bump. Whereas insertion torque is less likely to see, increase in insertion torque is less likely to see a bump at 4 weeks. So we know that these two measures are not necessarily congruent, and you should start to look at things a little bit more from a biologic basis with ISQ. So what was the take-home message to me from this? I mean, I do all this time in my practice. I try to dispassionately look at what I'm doing. The take-home for me is maybe I should start to get more aggressive with when I'm provisionalizing patients. Because that's inevitably, colleagues, that's what we're in business to do. We're in business to help our patients. And patients don't want to walk around being in Florida with dolphins in their mouths. Flippers. They hate those things. If we can get those removable appliances out of their mouths sooner, the better they'll be. So, when we have a maxillary first premolar, this was the first case where I did it with the Versah drills, and I always believe walk before you run. I'm not just going to start off with a provisionalization case. I took the first premolar out. This is a patient who's about 60 years of age and good health. I placed the implant immediately. There was minimal to no buccal gap, about 1 millimeter on placement. The insertion torque was 50 Newton centimeters, very high, and the RFA is 7280. He didn't want to walk around with a gap or with a treatment partial, so we provisionalized him. I made a temporary crown that day, placed it, and he went off. Now, I was a little less gutsy at this point and didn't want to check RFA value until 6 weeks, which could be stupid on my part as well. But nevertheless, I looked, and lo and behold, in the buccal palatal direction where I had about 1 millimeter gap, the number went up to 80, and the mesiodistal, it remained stable. Now, the key element to this for completing the case is soft tissue healing. Some people proceed quicker than others, but at 80/80, there's no reason why we cannot complete the treatment for this patient, which you can see now is the final crown that he received at about, 2.5 months. What's good from my end as the surgeon is look at the bone stability in this, because the last thing we want to do is we don't want to reduce the height of bone. And having a platform switch implant here helps us to do this, because we bring that micro gap away where the inflammatory process of taking an abutment on and off, if it goes to the edge, might cause for slight crestal loss. So the next patient, I decided to get a little bit gutsier. In this early 60s female with a good medical history, I took out the second premolar due to a vertical fracture. Insertion torque again was high at 50 Newton centimeters, but the key number for me was an ISQ value of 76/83. Now the buccal gap was greater on this patient, so this patient received a bone replacement gap in the facial since it was about 1 millimeter or so, again using a mixture of 70% mineralized, 30% demineralized, and the whole concept of a min-demin goes back to the days in the 1980s where Dick Shanneman and colleagues looked at this. I had an article that looked at the combination of min-demin, and it's, I think, a good one because you're getting some of the inductive benefits of the demin bone and some of the conductive elements of the mineralized bone. So tooth was provisionalized, out of occlusion, and the patient was sent off. And so I decided to look at 2 weeks this time. I took the crown off. Now, the buccal palatal saw a rise, which we would call a bump. The mesiodistal, we would consider this a dip. So what we're seeing here, nevertheless, is absolute values that would suggest that what I did wasn't foolhardy. And at 4 weeks, the original bump came down as people were discussing that you may see dips more towards 4 weeks, but look at the absolute numbers. It's still above where I began in both the buccal palatal and the mesiodistal dimensions. And this patient, as you can see, the healing is progressing nicely, will be able to get a crown before 3 months, a permanent crown. Would I do this on a regular basis, taking 2 and 4 weeks? No. The way I look at patients now is I'll take the reading at 3 weeks, and if I don't see a dip or a dip at all that's substantive, they go back to their dentist. I don't need to see them again. I save them and myself a visit. So we continue to push the limits, and I have to thank my friend Ziv Mazer, who introduced me, who told me that the use of Versah would be a game changer for sinus lift. And here is a case where we're going to do this using the Versah drills, and we're going to do this as an internal sinus lift. And I have a little bit of experience with this because I wrote a paper that was a multi-center back in 1997 with Rich Lazara, Bob Summers, and colleagues. And what we noted was, we came up with that 5 millimeter measurement. So when you hear 5 millimeters or greater or below 5 millimeters primary bone there, that you might lose 10% more implants, what we found is that this was a number. We always look for 5 or better to do osteotome procedures. Well, this was less. This is at 4. And we're using the Versah burst to elevate through hepatic forces this membrane. And to me, the question is, which is more osteoconductive in the sinus area, the implant surface or the graft material? And I would tell you, I think the graft is more the implant is more conductive than the graft. So I like to put the implant in whenever possible. So my insert torque was 45 Newton centimeters and my ISQ was 80/80. Allowed to heal. And at 3 weeks, the ISQ, in essence, stayed stable, except for a slight dip in the mesiodistal direction. And he was completed. The take-home message, though, is that our patients don't always read the textbooks that we write about them. And there's a phenomenon that I call bungee dippers for patients. This happens to be a bungee dipper. This lady in her late 60s came to me, and I see about 1 or 2 a year where the RFA, the Osseodensification, saves my rear end, comes to me with a hopeless first molar. I extract it, debride the site, place the implant with a graft material, again the 70-30 mixture, and send her off. At 6 weeks, she returned, 3 weeks she returned, but at 6 I took a measurement. Look at these numbers. I was so worried that I took a cone beam. I thought I had a failing implant. I decided to submerge it because everything looks pretty good around it, except distally towards the apex, you see that radiolucent area. I allowed this submerged to heal for 16 weeks, and miraculously, and I've seen this happen before, it rebounded. Some people just don't read the textbooks and take longer to heal. That's my take-home message about these. Whereas John Wooden, the UCLA coach, said, be quick, but don't hurry. So my conclusions on the use of Versah burrs today with osseodensification is that the RFA values achieved at implant placement have often been sufficiently high to consider provisionalization. The insertion torques have also been consistently in a range to consider immediate provisionalization as well. The vast majority of implants displayed stability using a densification strategy, looking at RFAs at 2 and 4 weeks post-placement, with bumps being demonstrated far more frequently than the dips. When dips have occurred, the absolute values are still meritorious to consider provisionalization, and you always have to weigh out the risk-reward when treating patients and trying to proceed faster because they don't read the textbooks that we write about them. And last but not least, today's evidence is presented on commercially pure titanium implants. I don't know that this translates over to alloyed surface implants. Perhaps it does, or how it relates to other implant systems. That and over a larger number will remain to be seen, and the anvil of time will certainly hammer out whether this is indeed the case. Last but not least, these are some of the people who helped make me look good today. The last two I would like to thank are Ziv Mazer for introducing me to this concept, and Salah Huwais, who's become not only a dear colleague but a friend as well. And I thank him for his great contributions to our field of dentistry. And with that, I would like to relinquish the stage to our next colleague, Paolo Trisi. So thank you for your time and attention today.